Welcome. So today we are going to be talking about the infertility evaluation. My name is Jill Attaman, and it's a pleasure to be here with you.
Good afternoon, everyone, and welcome. On behalf of Boston IVF, we're pleased to host today's webinar, the Fertility Workup, with Dr. Jill Attaman from Boston IVF, an IVI RMA North America partner. Before we get started, let's review a few important details about today's event. Physicians in attendance today will receive an AMA PRA Category 1 credit, and all other providers will receive a certificate of completion for 1 hour credit. The certificate will be emailed to you by Harvard around midsummer. Today, we're excited to welcome Dr. Jill Attaman. She earned her medical degree at Michigan State University College of Human Medicine, completed her residency in obstetrics and gynecology at The Ohio State University, and went on to complete her fellowship in reproductive endocrinology and infertility at Massachusetts General Hospital. Dr. Attaman sees patients in person at the Concord, Mass office and offers telehealth appointments for patients throughout Massachusetts and New Hampshire. She also performs fertility procedures in Waltham. With that, I'd like to officially hand things over to Dr. Attaman.
Thank you. I really appreciate the introduction, and I'm excited to be here to talk about something I'm so passionate about, which is infertility and what I enjoy spending my days and my time on, and hopefully helping people with their family building goals. So thank you for being with us. I have no disclosures today. We do have some learning objectives to cover. My hope and my goal for this time with you is to identify when to initiate testing for infertility based on patient age and other pertinent findings, selecting the appropriate fertility testing for a patient that you may be interested in initiating testing on, interpreting findings and very common findings that allow for treatment initiation and consultation. So with that, I like to start with a case. This is a 38-year-old G1P1 patient, pronouns she, her, with her 37-year-old partner assigned to male at birth, pronouns he, him. They come in with concerns for increased time to pregnancy. The couple has not been preventing pregnancy for 1 year. The female patient has a 4-year-old from a previous relationship. And we'll take this case through the presentation today as an example of the fertility evaluation and workup. So this couple also discloses that time to pregnancy during the first pregnancy was very quick for the female, a couple of months. The child does have cystic fibrosis. The patient reports regular menses on combined oral contraceptive pills in the past, and they did remain regular after coming off of the birth control pills. So often we hear that individuals have irregular cycles after discontinuing birth control pills, and it is a concern that does not come up infrequently. In general, folks can be on birth control pills for a very long time, and unfortunately, things can change during that time frame. For this individual person, it did not. Cycles remained normal, which was great. For other folks that might review irregular cycles after coming off of the pill, maybe something changed while they were on the birth control pill, as many individuals are using contraception for a number of years, and life and health can change during that time, and different presentations can occur. Fortunately, we're not in that situation. She's also very healthy. She's no prior surgeries. She's not taking any medications. She's an ideal person for preconception counseling because she's already taken her prenatal vitamin with folic acid. So somebody has already told her this is a great thing to do prior to attempts at conception. She's employed as a teacher. She exercises modestly at least 3 times a week, follows a balanced diet, so very balanced nutrition, no history of infections in the past, no smoking, alcohol use, or other substances, all important components of taking a medical history when reviewing fertility and time to pregnancy. BMI is 20, Physical exam is unremarkable. And then we talk to the patient's partner because they are presenting together, or the patient is giving information on the partner. Typically, when one presents for a fertility consultation, we're seeing people together if they're coupled. This patient's partner also reports good health, does not have erectile or ejaculatory dysfunction, does endorse some stress with timing. Now, this is not uncommon to hear. Often individuals do feel stress with needing to time intercourse if individuals are actively trying mid-cycle or timing things to ovulation predictor kits. So I often offer some reassurance that this is not an uncommon thing to hear. No prior infections for the patient's partner, no exposure to sexually transmitted infections in the past, no prior attempts to conceive, no medical problems or past surgical history. So, two healthy individuals trying to conceive. In a partnered couple who has sperm and egg, a typical question that might be asked is what percent of individuals conceive after 1 year? And I do share this information. Most people do conceive within 6 months of attempts. However, up to a year is still very reasonable probability of pregnancy, and this is fecundability. So the probability that a cycle will result in a pregnancy or a positive pregnancy test. There are a group of individuals that will still conceive after 1 year and up to that 2 year mark and even beyond. However, the majority are pregnant within 6 months to 1 year. And the probability of pregnancy is really greatest in individuals that are of a young reproductive age. So even with perfectly timed intercourse, the best that we can expect is 35% in a very young, healthy, coupled individual. Peak fertility is quite early. It's in the 20s, and this surprises some people that are not used to talking about age at such a young reproductive age anyway. 38 is generally young and healthy. However, peak fertility has passed. Relative fertility is decreased by 50% in individuals in their late 30s, such as our patient. So, how do we define infertility? The inability to become pregnant despite 12 months of trying to conceive without using conception in women that are less than 35 years of age, or if they're 35 years or older, 6 months of attempts. So duration of time does matter. It becomes more challenging to conceive at more advanced reproductive ages, so the time to pregnancy interval is decreased. If somebody's 40 years of age or older, it's not inappropriate to initiate an immediate evaluation and treatment given the advanced reproductive age, or if there's any known condition to cause infertility, so elevated risk. And this is from the Practice Committee of the American Society for Reproductive Medicine from 2020. Now, in 2023, the definition was updated, and I'll take you through that in one more slide. But first, we'll talk about what are some of the reasons that may prompt a more immediate evaluation, somebody that shouldn't be waiting that 6 months to 1 year. Well, this may be an individual that doesn't have periods or has very, very irregular cycles, perhaps somebody with polycystic ovarian syndrome. Known or suspected uterine tubal or peritoneal disease. Advanced stage endometriosis. These folks are often evaluated earlier as well. Known or suspected sperm factors. So does the male know that something has been occurring such that it has affected the semen analysis? Now, the definition update includes the factors that we just reviewed in the typical time frame to try for pregnancy prior to evaluation, but it also is more inclusive. And again, this was updated at the ASRM meeting in 2023 or just prior to. It includes the inability to achieve a successful pregnancy based on patient's medical, sexual, reproductive history, age, physical findings, diagnostic testing, or any combination of the above. So we're worried about somebody and their fertility potential. They should have an evaluation. Or if they have a need for donor gametes, donor embryos, donor sperm, donor egg, the use of a gestational carrier. So this would include individuals based on time to pregnancy, but it's also much more inclusive. It does nothing in this definition is used to deny or delay treatment to any individual, regardless of relationship status or sexual orientation. And we can find this in the practice committee for ASRM in 2023. When to consider an immediate referral, in addition to some of the factors that we've already reviewed, somebody that may have a known genetic carrier status. This couple that we are discussing does have a child with cystic fibrosis, albeit with a prior partner. Perhaps they're concerned about the current partner's carrier status. Recurrent pregnancy loss, again, donor gametes, very prompt referral, or interest in reciprocal IVF. Medical needs for gestational carriers. Infertility is not uncommon. This happens and occurs in around 15% of couples that do have exposure to egg and sperm, and often the etiology involves both people. It is difficult to establish causal relationships when really talking about infertility. Often more than one etiology is present, and it's very similar with primary or secondary infertility. Perhaps somebody has had pregnancies together in the past very easily. A little time has passed, it's become more difficult for their second pregnancy. Again, estimates are a little challenging, but I do put them up here to highlight the fact that it is not uncommon to have unexplained or idiopathic infertility. This can occur up to 30% of the time. Male factor is also very common. So, initiating an evaluation for a female, for example, who's coupled with a male, if everything comes back normal, male factor testing is very relevant, or testing at the same time. Ovulatory dysfunction is often seen, tubal damage, other concerns are rare, endometriosis is not uncommon. ACOG and ASRM came out with a joint committee opinion that is very comprehensive in regarding the initial infertility workup, and we'll take this part step by step and take you through the case that we started with. So first, we're getting the comprehensive medical, reproductive, and family history, a targeted physical examination. We're talking about optimization of general and reproductive health. My rule of thumb is anything that affects general health can also affect reproductive health, which is why I do focus on nutrition, a balanced diet, movement, mindfulness, stress reduction, sleep. Some of the things that we know keep people healthy also help their reproductive status. We do talk about exposures to things that are generally avoided during pregnancy as part of the preconception care and counseling. This would be alcohol, nicotine, opioids, other drugs, adding in folic acid supplementation or prenatal vitamin, which our patient was already on, talking about healthy body weight, exercise and movement, exploring environmental occupational exposures, and then talking about genetic counseling and screening options if that is something that one is interested in. Specific details also involve duration of infertility if they've been attempting, menstrual history, gynecologic history, prior contraception, how often intercourse is happening if this is applicable, if there's any sexual dysfunction, and again, exposures listed here. Partner history is also taken, review of past medical history, surgical history, medications, allergies, family history, a review of systems, talking about ancestry and any genetic risk assessment. Again, environmental, occupational exposures for the partner, prior family building attempts, and prior testing. Any discussion regarding fertility generally does begin with a conversation involving age. So age does bring with it decreased ovarian reserve, increased oocyte aneuploidy, so abnormal chromosomes. Chromosomal abnormalities in pregnancies happen much more frequently with increasing age, which also leads to increasing miscarriage rates, as does medical history and any medical changes that occur throughout time. I often share this because I do think the reproductive system is so prone to biology and it's just so challenging. Somebody with ovaries has the most follicles that they will ever have while they're 20 weeks gestation, so prior to birth. And unfortunately, by puberty, we're down to about 500,000. By menopause, around the average age of menopause at 51, it's around 1,000 follicles. So depletion happens pretty rapidly. Miscarriage rates also increase fairly dramatically based on ages. We know miscarriage happens in individuals that are without infertility, but it also happens throughout the infertility course or infertility care. We do know by looking at certain societies of individuals that have pressures to never prevent conception that throughout the lifespan, the average age of the last pregnancy tends to be around 40 or 41. And you can see this in multiple different groups on this slide where it's quite exponential. Age of female is extremely important. Some people are surprised to hear this type of information. In regards to the menstrual cycle, in general, menstrual cycles would be anywhere from 24 to 38 days. Most commonly, it's around 28 to 35. Less than 1% of women with regular cycles have ovulations outside of this window. Generally, the difference in menstrual cycle interval is related to the follicular phase variation, meaning how long it takes a follicle to grow. The luteal phase, the time frame after ovulation, is generally quite fixed, around 12 to 14 days. It can be a little bit shorter, which is when some of the questions about whether there's luteal phase deficiency or not come forward. When discussing fertility, I think it is helpful to talk to patients using the words that they're going to hear about and the phrases that they're going to need to learn about. So I typically start at the pituitary gland, and I joke because I end up pointing to where my pituitary gland is quite frequently if I'm talking to individuals. But the pituitary gland will make hormones. Those hormones are follicle stimulating hormone, FSH, and luteinizing hormone, LH. LH is the hormone that is detected if individuals are using the ovulation predictor kits. FSH is follicle stimulating hormone. It's actually very appropriately named, and in medicine, we know that can be sometimes a rare event, but it does work to stimulate the follicles in the ovaries. And with follicular stimulation, the ovaries will start to make estrogen, and then eventually ovulation happens in response to LH, and progesterone is the predominant hormone produced at that point. But these two hormones feed the uterus and help the uterine lining develop and grow such that if one is trying to become pregnant, it is receptive to a pregnancy. So this is a very typical example of what we might see for follicular development and the hormones that are governing it, in addition to how the endometrium is responding. First, we'll see the FSH. FSH actually starts to rise in the luteofollicular transition, so prior to the menstrual period. But it will progressively increase, it's shown here in the green line, throughout the follicular phase. And what that is doing is recruiting a group of follicles. This diagram shows one follicle with an egg inside that's growing throughout time. In general, there's a number that are doing this. However, one does become dominant. Estrogen starts to rise. The other follicles, unfortunately, are never used again. Those undergo reabsorption. This is how age ends up mattering in regards to ovarian reserve. The estrogen becomes high enough that it feeds the uterus. The uterus starts to develop an endometrial lining, and there's a positive feedback mechanism that happens such that luteinizing hormone causes the egg to ovulate out of the follicle, and a corpus luteum remains, predominantly produces progesterone and some estrogen, feeds the uterus, and it becomes receptive for a embryo to implant if the goal is pregnancy. Now, some people do want to talk about how to assess ovulation, and this doesn't come up infrequently. So there can be changes in cervical mucus. There can be increased libido. Some people experience pain with ovulation. The peak time to try to become pregnant in an unassisted conception, meaning folks that are trying without any assistance, would be when that cervical mucus looks slippery and clear. That's a sign that estrogen is starting, or estradiol is starting to rise, and that happens in the 5 to 6 days prior to ovulation. We can use ovulation predictor kits to detect the LH surge. People typically will start testing a few days before a mid-cycle time frame in a 28-day cycle like our patient has. This would be around cycle day 14, and ovulation is not infrequently detected on ovulation predictor kits or other methods as well. Historically, basal body temperature used to be used, and we may, folks on this webinar may have seen some of the basal body temperature charts. They're fairly detailed and difficult to truly use because it is retrospective. What we're seeing in the chart that I have here is that progesterone has caused a rise in elevation of temperature, but it happens after ovulation. However, this is the basic premise of some of the biometric markers that are being used in medical devices that people may come in talking about, to say, hey, you know what, my body temperature did rise, and I do think that I ovulated on this day. I also have symptoms, for example. Ovulation predictor kits could confirm that if they wanted to use them, or a luteal phase progesterone can. Optimally, progesterone is evaluated about a week after ovulation, 7 to 8 days, and progesterone levels should be greater than or equal to 3 nanograms per milliliter to determine that ovulation has happened. Anything less than that would mean that that was likely an anovulatory cycle, meaning progesterone didn't rise. It's very difficult to measure progesterone levels and interpret meanings of different numbers because the corpus luteum that's produced after ovulation is pretty susceptible to the pulsatile nature of the GnRH, and progesterone can fluctuate pretty rapidly. Within a 90-minute time frame, it may change eightfold. So it's not very reliable. So let's return to our couple now and say, okay, we've had a conversation about menstrual cycles, history, ovulation. What test should we order? Well, let's start with talking to them about the ovulation, which we've done. For this couple, we're going to check a luteal phase progesterone, excuse me. And this comes back greater than 3, so it is 4.2. The individual is ovulating, and it is consistent with some of the symptoms that she also reports because she does think she is ovulating. What may be next? Ovarian reserve testing. So I'll break it down into ovaries, uterus, tubes, and sperm, all the essential components of fertility. There are a number of different ovarian reserve tests that can be used. They do help predict response to in vitro fertilization if individuals are going to go forward with IVF, for example. It is difficult to use these tests to predict the ability for somebody to conceive in an unassisted fashion, and they're generally not recommended for individuals that do not have infertility, as it's difficult to interpret the results and find them meaningful. We can also look at blood work on the third day of a period. We talked about FSH, LH, and estradiol. So these are evaluated at basal levels. Anti-Müllerian hormone is a very reliable marker of ovarian reserve when women do have infertility, as is something called the antral follicle count, which is a physical assessment of the follicles performed via transvaginal ultrasound in most cases. And this would be an example of what an antral follicle count would look like. If you can't see, there are small little follicles. These are black spots here in the ovary, and that's where the eggs are resting and waiting. There's also a Clomid challenge test. This has largely fallen out of favor. It is sometimes useful in certain circumstances, but it doesn't improve test accuracy for predicting a poor ovarian response. This is less frequently used than it may have been a decade ago or even 5 years ago. The basal FSH does have a high specificity for predicting a poor response. And again, that Clomid challenge test, which is when an individual will use a medication that will also potentially be used for fertility care to test a pre and post FSH level. AMH. So anti-Müllerian hormone is one that is quite reliable and will be tested for in our patient. It's derived from the granulosa cells of the preantral and small antral follicles. It reflects the size of the primordial follicle pool, and this can really be obtained at any time during the menstrual cycle. A tendency is to do it on the third day of the period because we do the other testing for ovarian reserve on the third day of the period, but this can be done at any time. It assists to select and predict response to controlled ovarian stimulation. It is not a test that should be used to refuse or deny treatment to any patient. And unfortunately, it's not predictive of reproductive potential among women with unproven infertility. The antral follicle count is another very reliable way to assess ovarian reserve. These are small follicles within the ovaries that are 2 to 10 millimeters in size, and they have a high specificity for predicting a poor response as well. So this ends up heavily weighing on some individuals' approach to determining and predicting which type of medications or which type of protocol for something like in vitro fertilization could be useful. And a few pictures here. Again, this was an antral follicle count. One follicle is a little bit larger. I don't know the exact size of this, but it might fall outside of being an antral follicle, one that's starting to grow and develop. An individual that may have polycystic ovarian syndrome. This is not diagnostic for it, but it does look like a typical morphology where the follicles are off to the sides, the outer rim of the ovary with some intervening stroma, and somebody with really diminished ovarian reserve. Right here, we see maybe a follicle within the ovary. Normal AMH should be above 1. An antral follicle count, we'd like to see at least 5 to 7. Some will say 10 to 15 would be considered more normal. And then FSH is abnormal when it's greater than 10. So now we test our patient for ovarian reserve and we find that her FSH is normal, it's 8.3, estrogen is 50, AMH is 1.9, and her antral follicle count is 15. So everything looks reassuring in regards to ovarian reserve. So the next test we move on to will be a uterine cavity evaluation and a tubal evaluation. The uterine cavity evaluation can be done a few different ways, as can a tubal evaluation. This would be the first example of one that looks at both. This is an HSG, a hysterosalpingogram. This would be a small catheter and an example of one that might be used. A speculum is placed into the vagina. A catheter is threaded gently into the uterine cavity. You use just a very small balloon at the end that is inflated to help hold in the contrast that is then placed into the uterus. So it is not a very comfortable procedure. Pre-medication with Motrin is very much appreciated by most people if they can tolerate Motrin. This will cause cramping. It causes cramping because there's a device that's being placed in the uterus. It's uncomfortable positioning, and then we are placing further dye through to try to determine if the fallopian tubes are open. As you see here in this example, the fallopian tubes appear like thin little rubber bands, and they're spilling dye out such that it's starting to outline bowel. This would be an example of looking at the uterine cavity alone without a tubal evaluation. I like this because I grew up with a netter, so I can see that on a 3D reconstruction for a saline sonohystogram, it looks a lot like what netter looked like when I was learning about anatomy. And this will give us a very good assessment of if there's anything in the uterus that could impact fertility. Some of those things include uterine anomalies, uterine polyps, fibroids, intrauterine adhesions. So we can see these things on uterine cavity evaluation. If an HSG is being used to evaluate these defects, they do appear as filling defects. On a saline sonohystogram, the same, but we get a little bit more information about how the muscle of the uterus looks as well and how the external contour of the uterus may look. Here's a couple more examples of the HSG. You can see when the uterus is in different flexion points, which are both very normal. It can look a little different, but both tubes are patent or open on both of these examples. This would be an example of a patient that does not have an open tube. So we'll be focusing here on the right, where you can start to see that the fallopian tube from the uterus is very thin and flimsy, but then it starts to collect dye and become more dilated. It never spills dye, so this is considered a hydrosalpinx. The difference in this picture is it's inverted, so the looks black as opposed to white on the other images, and a Jarco catheter, which is just a different type of catheter to introduce dye is being used here, and you can still see the speculum on the fluoroscopy. The uterus here is tilted back, so here's the fundus. The other tube is open. And this is a dynamic test. It's much easier to interpret when you're looking at an HSG while performing it. However, still images are just fine as well. This is an example of what we abbreviate as a Hycosy, a hysterosalpingo-contrast sonography evaluation. This is another way to not only look at the uterine cavity by introducing water to the uterus, so it looks like that netter picture, but also by agitating saline with air bubbles and then allowing them to flow through the fallopian tubes such that you can see those agitated saline air bubbles or contrast, if contrast is being used, because that is also an opportunity here to go around the adnexa. So this is a short video clip. I'll show it once. What you'll first see are some air bubbles in the uterine cavity. This one's being used with water and air. And then what we'll be looking for is the same little air bubbles coming through the adnexa. So I'll show it twice here. So first you see it collecting the uterus, and then you see that these air bubbles are going to be coming around the adnexa very clearly here. This is a patent or an open tube. This test can be done in the office. It doesn't require fluoroscopy, so there are some advantages to doing it if it's available to you in your setting or in a hospital setting or your consultants. Unfortunately, here's an ultrasound that gives us an example of the opposite. This is a hydrosalpinx. So this patient on imaging has a very dilated tubular mass that you see here, and this ends up being a left hydro. This is our case patient. So our patient ends up with a left hydrosalpinx while we're doing their evaluation. So on a Hycosy, we do see a normal uterus, but we see a left-sided hydrosalpinx. Hydrosalpinges, this would be qualifying for tubal factor. They do have a detrimental effect on pregnancy rates and live birth when we're using fertility treatments such as IVF. It is associated with a 50% lower pregnancy rate. So often we do talk to folks that are proceeding with IVF about removal of a tube or clipping of a tube. There's a mechanical disruption that can happen within the uterus by having some of the flow of that fluid go backward into the uterus. It can impair endometrial receptivity. It can be embryotoxic. There's inflammatory substances that can be introduced into the uterus that are less favorable as well. So it's not uncommon to talk about salpingectomy. Now we're moving on to the partner and the semen analysis. So analyzing the sperm. And we analyze the sperm with the semen analysis to look at volume, concentration, motility, and morphology. Morphology would be the shape. So I'm showing here a sperm and how many components the sperm has, the head, the midpiece, the tail. There can be defects in any portion of this sperm. In order to prepare for a semen analysis, one is asked to abstain for 2 to 7 days, produce a sample with a sterile collection container, and then the analysis is generally presented to a facility within around an hour or produced on site. It depends on what's available at your particular place of practice. The sperm should be kept at body temperature if traveling with it. It is not something that we want to see in a cooler as it comes in, but a coat pocket perhaps would be a good place for the sperm to be stored during the transport. And if it is abnormal, we generally do recommend a repeat and consider further testing or referral. Now, what I'm showing here is the WHO fifth edition semen analysis parameters. And the reason that I'm showing the fifth edition, even though there's an updated sixth, is that we still often use one of the parameters that was eliminated from the newest edition, and that's sperm concentration. So 15 million per milliliter is still a commonly referenced range and is not included in the next edition. And that was to try to make it more meaningful despite changes in the seminal vesicle fluid. So here we see that total sperm number comes into play at 39 million per ejaculate. The total motility is around 42% with some variability of a confidence interval of 40 to 43. And morphology or shape of the sperm, at least 4% of sperm should be shaped normally in order to be considered a normal semen analysis. And these reference ranges were developed by looking at the lower fifth percentile of individuals that had partners that conceived within a year's time frame. The sperm is the sole etiology for infertility in around 20% of individuals, but it is present in approximately 40 to 50% of evaluations. And any abnormality warrants a repeat and a referral to a reproductive urology or reproductive endocrinology if that is the referral pattern. So for our patient, we did the semen analysis. We were able to see that the volume looked fair. Unfortunately, the count was low at 4 million. Motility was around half of what we'd expect at 20 million, as was the morphology or the shape. Now, the shape of the sperm historically has been considered a pretty good predictor of how successful fertilization events can be. It's now a little bit more controversial, so we'll have to see where that lands. But less and less emphasis is being placed on the sperm morphology in the more recent literature. We do repeat a semen analysis for our patient. It's similar, so now we're referring to male reproductive urology, or again to a reproductive endocrinologist if that's a more appropriate referral. Some common definitions for semen analysis and some common terms are included here. I'd like to point out the resource. It's a really nice resource from the AUA and ASRM from 2024, an infertility guide for male infertility, oligospermia, which is low sperm concentration, asthenozoospermia, which is low motility, and teratospermia or trisospermia, which is the low morphology or normal. And here's a nice algorithm from the same guideline in 2020 that outlines how males may be evaluated. If there is oligospermia, taking a look at hormones like FSH and testosterone would be recommended, and further evaluation and management. This is also assuming that the male has had a complete history and physical exam, which should be performed when there is an abnormal semen analysis parameter. If there's normal sperm, well, maybe we're treating a couple with IVF or ovulation induction and IUI. If there's azoospermia, there's lack of sperm, then there's another cascade that can be followed. We first look at FSH, and then we determine if there's an obstruction or no obstruction. If it's non-obstructive, then perhaps there's a genetic factor. Two common things to have performed based on the concentration of the sperm would be a karyotype, looking to see if there's something like Klinefelter's that's present, and or a Y microdeletion. When the sperm count is very low, a Y microdeletion is often performed by the urologists or the male reproductive urologists. If it's obstructive, then cystic fibrosis testing is happening. We want to make sure that there's vas deferens present. There could be other things that are present that are causing the obstruction, and maybe an ultrasound is being performed. There are multiple etiologies to male factor infertility. There can be endocrine and systemic disorders, primary testicular defects, sperm transport disorders, or it can be idiopathic, an abnormal semen analysis and no apparent cause. So for our patient, we do refer. He does have serum testosterone levels drawn, FSH, LH, estrogen, prolactin to take a look at whether there's a cause for the oligospermia. There's a physical examination that's been performed, and these return normal for our patient. There was a karyotype performed as well because the count was persistently less than 5 million, but was not low enough to do a Y microdeletion, but the karyotype did return normal. What other tests would we want to think about in our case? We've now gone through looking at ovarian reserve, uterine health, tubal patency, the semen analysis, a reproductive urology referral for our male patient. We recall that perhaps our female patient mentioned that she has a child with cystic fibrosis. So the couple does elect to have expanded gene screening. They undergo the screening. The current male partner is not a carrier for cystic fibrosis. However, we find that they're both carriers for spinal muscular atrophy, which is not an uncommon autosomal recessive trait to see. Since this is an autosomal recessive trait, the couple have a 25% probability of having a child affected with disease, and there are certain things that we may want to talk to them about. So, what have we learned about our case? We've learned that there's advanced age. This is present. Our couples 38 and 37 respectively. We've learned that there's not ovulatory dysfunction, so this is absent. That's a good thing. We've learned that the uterus looks okay. There's no polyp or fibroid, scar tissue. However, we have seen that there's a left hydrosalpinx, which can be detrimental depending on what they're opting for fertility care. Also places a patient at higher risk for ectopic pregnancy, no matter how they conceive. Male factor infertility is there. There's oligostheroterapspermia, so low count, shape, and um, motility. Please forgive me. Genetic, we do understand that there's overlapping autosomal recessive trait that is present, which is the spinal muscular atrophy. So they come and ask, what can I do that will help me have a healthy pregnancy with a child that is less likely to be affected with spinal muscular atrophy? They do have choices. In vitro fertilization with pre-implantation genetic screening for a monogenic disease, so PGT-M, meaning the single gene disorder, is an option. Undergoing intrauterine inseminations for the female with donor sperm is also an option. That eliminates the risk of the spinal muscular atrophy. IVF with donor oocyte would also be an option. However, the ovaries look like they're doing okay in regards to ovarian reserve. Alternately, embryo adoption, foster parenting, not expanding their family, and unassisted conception remain available to them. There are advantages and disadvantages to each way that they may choose to proceed. Our patient does opt to choose for IVF with PGT-M and pursue a salpingectomy because there is an abnormal tube present. So this is the example of that hydrosalpinx and how the ultrasound previously looked. We can see on a laparoscopy, it's a big dilated tube. And after the salpingectomy, the tube has been removed. So any of these inflammatory substances that may be traveling backwards to cause a mechanical or a chemical toxicity to the embryo implantation are now absent. And the other tube is very normal. And then they're going to go through IVF. So very briefly, they'll go through maybe a pre-medication step. They're going to go through creating probes that can detect the spinal muscular atrophy in the embryos once they are produced, ovarian hyperstimulation, egg retrieval, which is removing the eggs from the ovaries, fertilizing the eggs in the embryology laboratory using the ICSI procedure for this couple. We're using intracytoplasmic sperm injection for a couple of different reasons. One is the semen analysis and the low count. The other is that it's preferable for the PGT-M to be performed at this point. And then eventually we'll go forward with an embryo transfer and supporting the pregnancy. I've used the term PGT-M, which is pre-implantation genetic testing for monogenic diseases. This term has replaced PGT, which hasn't been used for a number, PGD, forgive me, has not been used for a number of years now, however, may be more familiar to some people. And PGS was replaced with PGTA, which is the pre-implantation genetic testing for aneuploidy. And then there's PGTSR. This is the PGT testing for structural rearrangements. So our couple has embryos that develop to the blastocyst stage, which has about 100 to 200 cells in it. And then it's biopsied. This is just an example of what delicate work our embryologists do in so many different places to remove a few cells from the area of the embryo that eventually will be forming the trophectoderm and sending this cell biopsy off to be analyzed by a genetics laboratory that will look for the SMA. And the embryo is cryopreserved. And then eventually we're able to place an embryo back. Some cases, those embryos are tested and placed back pretty immediately, depending on the location and technology available. So, in conclusion, we've taken our patient through. They have a very successful pregnancy and a happy, healthy family. We've defined infertility, when to initiate testing, considering risk factors and referral when it's present. We've talked about selecting the testing to order, interpreting the findings. We've also reviewed optimization of unassisted conception so that our patients learn what they may be doing or not doing that can help if they choose to proceed without fertility care. And I would like to thank you for your time. I very much appreciate it. And I know that we have just a few minutes. So what I will do is then turn attention to see if we have anything in the Q&A. All right. So we do have some questions, and I will do my best to repeat the question and answer it. So the first question, what do I say when a patient asks for AMH tests to see how many eggs are left? It's not a recommended test to see how many eggs are left for an individual. This is a test that really is designed for fertility care. I think getting a good history for this patient and understanding what menstrual cycles may be like could be the most relevant in addition to considering reproductive age. If an AMH is being performed, then it is traditionally to be used for fertility planning. It will not be a good test to see how many eggs they have left, how long they have until they can conceive, or when the time frame will be where they need to present for fertility care unless they're ready for pregnancy. And anytime there's questions, please go forward and refer to a reproductive endocrinologist. It's a very common question to have come up. Next question. For uterine and tubal imaging, do you have a strong preference for which imaging procedure you start with for the average patient you see? I think it depends on the patient. So if there's strong suspicion for tubal factor, well, first, they're both very good tests. If there's a really strong suspicion for tubal factor, my personal practice pattern is to think about an HSG first because I really like to see the fallopian tubes and where the dilation is at if there is tubal disease present. However, if I'm seeing a patient with recurrent pregnancy loss, I think that something that gives me a 3D rendering of the uterus is a little bit more helpful with a tubal evaluation. Um, Contrast allergies, I tend to avoid an HSG because the other one can be done with water. In somebody that has a poor experience with prior testing, perhaps due to pain, both tests, unfortunately, are not comfortable, but I tend to recommend a Hycosy or the uterine cavity evaluation with water over an HSG just because it is done in a regular examination room. It's not done on a fluoroscopy table with a C-arm. But those are personal preferences. Everybody will have their own preferences. There's a couple questions that were very similar to that, so hopefully I have addressed that. Let's see. How would you counsel a couple experiencing 1 year or more of infertility with normal baseline evaluation and workup, but do not qualify for IVF through their insurance and can't afford it? This is so hard. IVF certainly is not inexpensive. So if it's been over a year, a normal evaluation, there are also candidates for ovulation induction and intrauterine insemination. Ovulation induction can be with the use of clomiphene citrate or femara. These are medications that help ovulation occur in producing more than one follicle at a time, and then combining that with an intrauterine insemination. Maybe a few attempts at ovulation induction and IUI, which could be more favorable from a cost perspective. I do often talk to individuals that are in this position about ideal family size as well, because going through multiple ovulation induction cycles with or without IUI, and I would recommend an IUI if it's unexplained, can be expensive too. And it takes time. So if you have a patient that comes in that's a bit older, it may not be for this current pregnancy, but maybe if they're thinking 2 or 3 pregnancies, time will add up. All right. I know that is now 1 o'clock, and I am so sorry that I haven't gotten to all of these questions. I do appreciate all of your time. It has been an absolute pleasure, and I am hopeful that every patient that you have experiences success with their family building.
Thank you, Dr. Adaman, and thank you everyone for attending today's webinar. If you have any questions, please contact Alyssa Cooper at ecooper@bostonivf.com. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate if you would complete the survey and provide your feedback to help with future educational webinars. You will also receive a follow-up email within 24 to 48 hours with a link to view the recording of today's webinar. On behalf of Boston IVF, IVRMA North America, and Dr. Jill Attaman, thank you for joining us and enjoy the rest of your day.